like I said, this is work, that has been mainly driven by Abigail. And in terms of doing risk stratified COVID, we've added a policy component to this. So we now have that in the title, policy analysis for LA County, in trying to integrate a risk model and then also a stochastic epidemiologic model in doing this. Again, we've developed this epidemic model. We have LA County data. And we really were set out to sort of address three primary questions. The first one that was, most relevant, I think, early on in the epidemic was when and how would the epidemic impact healthcare capacity. Now, what we're doing with our model here is we're not doing any sort of projections in the future. We're looking at this past data and trying to understand the dynamics of the data within the time period that we have the data for. So we're really looking at how did the dynamic impact the health system, what was healthcare capacity, were we close to reaching capacity, so on and so forth. We were also interested in how did the epidemic affect different at-risk groups, and I'll get into how we define those at-risk groups. And then what would have happened to the dynamics under different policy implementations for social distancing, as well as protection of at-risk groups. And so we'll talk a little bit about that as well. And so, hold on. Why is our model? I mean, everybody's seen lots of different models out there in terms of these SEIR type of models. And so why is ours unique? Well, we integrate a dynamic epidemic model, okay, with a relative risk model. So we're trying to combine and project sort of risk groups onto that risk curves that you see from the epidemic models to produce time varying subpopulation stratified estimates. So it's really a balance between what we can do with the data that we have at hand versus sort of the refinement we can get with the risk model in terms of looking at subpopulations. And we really want to look at the severe illness probabilities, hospitalization, ICU, and death, as well as getting estimates of the case fatality rate and the infectious fatality rate by these risk factors. And so we construct 39 different risk profiles that are a combination of risk factors. That's age, existing health conditions, unhealthy behaviors such as smoking. And then we apply that to an epidemic model. In this case, we use a stochastic differential equations models with approximate Bayes calculation for estimation. And then our risk model is a logistic regression framework that we construct sort of without access to individual level data. And we'll talk about how we do that. And then one of the things we also want to do is sort of do a fair presentation of the uncertainty in all the estimations and the predictions, and then incorporate external information in terms of informing prior distributions, mainly leveraging mobility data to give us an idea of how that would impact the R naught as we go forward. And then again, evaluate alternative policy options for social distancing and protection of at-risk groups. I'm going to pause again here to see if Abigail has joined us.
No, not yet.
She has not joined us. Okay, let me just quickly check. Because the next section is her area of expertise, and okay, we'll keep going on. So we're going to sort of address sort of three parts here: the epidemic model, then the risk model, and then the scenario analysis. So here's the basis of the model, and you can see across that horizontal, this is, at its foundation, an SEIR model. So you have susceptibles going to infectious, or sort of to exposed, to infectious, to then recovered. These are given by a set of differential equations, and we are trying to expand that in two major ways. The first is to sort of expand on this exposed section, having two sort of possibilities of being infectious and observed, and then the other possibility of being asymptomatic or unobserved. So it's not necessarily just asymptomatic, it's unobserved. They haven't reached, they don't enter the LA County data. They haven't been tested, they're not observed in that aspect. The other part here is really this hospital system component here where we have this infectious component. They've been tested, they enter the hospital system. This is entering hospitals, and from there they can go into this component Q, which is the ICU component. And then that component onto death or to recovered or hospitalization. It can also go to recovered as well. There's this little box that comes off of this, the ICU component, and that is represents ventilation. We don't actually observe the number of in ICU by day. We do observe those that have been put on ventilators. And so there's a proportion of those in the ICU that will be on ventilators. These are described then, of course, by a series of parameters, and then we can inform these in this transmission of going from susceptible to exposed. It's a time-dependent factor, and we're going to sort of estimate an initial R naught, and then look at that reduction from the initial R naught over time. And that's where we can use prior mobility data to inform that reduction. And then the beta here is this transmission rate, or for the average number of individuals that are infected, that an infected individual will infect, okay? We're also looking at this proportion of infections that are detected. We really don't have information on this except from one seroprevalence study that Niraj did early on to inform us on this sort of proportion. And that's one study from LA. There are other studies out there. And so we sort of take the composite of all these studies to inform that parameter. But it's important to note that this plays a key role in our estimation of the infectious fatality rate, because we need to have sort of a denominator where it's the total number of individuals infected, not just those observed, that we can estimate infectious fatality rate from that aspect. And then we have parameters from the epidemic model in terms of the probability of being hospitalized, given that you're ill and observed, the probability of entering the ICU, given that you're hospitalized, and then the probability of death, given that you're in the ICU. So this is the set of differential equations that describe this process. I'm going to skip a lot of the details because this is the area of expertise for Abigail. Would come in and talk to you about how we set this up, but it really just sort of mimics what you see on the right there in terms of the diagram that we described there.
Just one question.
Yeah.
It appears that all deaths happen in the ICU. Are there other deaths?
There are deaths. So yeah, good question. So assumptions. We do all deaths. We assume that people will go into the hospital system if they're observed, and they will go through the process of hospitalization, ICU, and death. That is an assumption. There are other deaths. It's unclear, you know, how many individuals went directly from being infected and at home died and went to death that way. We don't account for that here.
There's no data.
Assumption. There's no data
from the county on deaths at home?
No.
I wonder if Erica maybe has some data on that from her California death certificate data.
You know, that's an interesting question. It would be something, yeah, interesting to sort of look at. You know, again, with the data, and I'll talk a little bit here about what we have in terms of observed, is just what's in the boxes. You know, total number infected by day, in the hospitals by day, on ventilators, and death by day, right? So that's a limited number of sort of components that we have of this model, and that limits us in terms of the estimation abilities.
So I will just say really quickly that in the death certificate data, we do have information about where they died. So inpatient in the hospital, other locations in medical care settings, as well as at home.
Okay. Yeah, that would be great to, you know, because we could put a line, you know, from the infections to deaths, and if there is sort of a proportion that we could get from that data, then we would be able to fit that, right? I mean, this is a theme that's going to come out through all of this, is this balance between the available data that we have versus the model we want to fit, and what we can obtain through estimation, right? As the model is right now and looking at it, and the data that we have available just looking at this, we can't estimate all these parameters. A good example is this R, the fraction that we can observe versus not observed, right? We can't estimate that from the data we have, but we can put sort of very tight priors on it, or just specify it as an exact value, right?
This is Anne. It seemed to me there should be an arrow from the A down to the I. You didn't know they were exposed, and but they became infected later. You got later.
We're assuming that it's just a simplified process of like ultimately everybody who's exposed goes either two ways. They are either completely sort of tested and identified, and that's this infectious component here, or they are unidentified and this component here. So don't think of this component as being just asymptomatic. It's really unobserved, and it can include asymptomatic or include symptomatic individuals that just stayed home and never got tested and never entered the LA County data.
The other thought I had is that some people could go from A to death. Like when they've looked at the excess mortality over certain time periods that could have been associated with COVID, these were people they didn't even know were infected. And then, they died of some respiratory problem or, heart problem or something like that. So I realize you don't have all these things able to be measured, but
yeah, no, there's, I mean,
excess deaths that were never identified.
Yes, absolutely. There, you could put, almost arrows from all of these, make this a much more complicated model. So it's a, again, it's a balance between sort of figuring that out. Let's see. So we represent this in terms, we take that set of differential equations, and it's a deterministic model that we can sort of implement. But what we want to do is allow for the stochastic nature of the data that we're observing, right? Not following an exact sort of our process of the differential equations. And then also we do have small counts at various times in this model. And so it's preferable to use a stochastic model to do this. And here we just use sort of a counting process to describe the flows from sort of what is the current state, we'll use susceptible here, and then how that then, in terms of the counting process of the number of individuals that would go from susceptible to exposed, and that then gives us the next time point in terms of the number of individuals within that component. Think of it in some sense as biostatisticians maybe think of it as a structural equation type of model where you're looking at the flows. And then this becomes sort of a Markov chain type of an interpretation. And then we can use through this process distributions that describe that sort of process in terms of binomial, if it's just going from a two-state type of situation, or a multinomial distribution with corresponding transition probabilities to describe that process. So I'm going to actually skip over the next couple slides because I saw them about 5 minutes before this talk. So one of the things that is important to calculate here is this R naught, and in a simplified SEIR model, it's worked out. It's easy to sort of interpret that as the number of infectious on average, infected individuals, that number of infections per time period that an infected individual will infect. But as you start to add more and more components, then the calculation of this becomes more and more difficult. And so Abigail did this through a spectral analysis of looking at sort of what's called the next generation matrix. And again, this is sort of out of my wheelhouse. And so hopefully Abigail will come on at some point in time and we can come back to this slide and she can explain the details of this. But you will see though that when we look at R naught, we're going to estimate it's still this beta parameter that drives it, but then it's a function of individuals going into that exposed component and how they go and like pair off into the different components as a function of this R as well. So that's the important thing to realize, that it's not just dependent upon sort of the next stage. There is sort of a feedback to that R naught, and the number that gets in the terms of going from susceptible to exposed is driven by more than just that simple process of that single step. Okay, in terms of estimation, the data that we've used for the parameter estimation is those given here in the model. It's in the red things. 1 second, I just want to check to see if I'm getting any notes from Abigail. Duncan, she hasn't joined yet, has she?
No, I haven't seen. I've been watching.
Okay, she hasn't responded to, so she must be having computer difficulties, but okay. So the model here, again, we're going to predict the counts over time, but we're limited to the data that we have. And the color squares indicate sort of what we do have. We have cumulative and new illnesses, so this I category. We have cumulative hospitalizations, new hospitalizations. By that, we have cumulative and also new ventilation, and then deaths as well. And then from the total that we assume in LA County of being 10 million, and those entering this process, then we can calculate those that are recovered from this. We're using sort of data here from March 1st to October 31st in what we'll see in the estimates that we're presenting here. And
does the data available to calculate R include those that went through A?
No, we have no idea about A.
Yeah, okay.
Right, but our estimate of R from the model, you know, we estimate that component of A, but we don't have that data, right? So you can see very easily that this is really sort of unidentifiable without any external information on this split, right? Okay, so how can we inform sort of this estimate of R naught, and really it's the estimate of the beta from other information? And what we do use is this mobility data from Unicast. And what you can see on the right here is looking at sort of the encounter density that they keep track of. And you can see before the pandemic, this is sort of pegged where the amount of mobility was in the population, and then that reduced greatly you know, around the time where there was the initial shutdown, and then how that looks over time in terms of changing that. So again, what are the idea here is to use this mobility data to inform the reduction in R naught as a time varying factor. And so what we're going to do in terms of the estimation is estimate the initial R naught and then look at that reduction in terms of a % reduction of R naught over time. So that's what we're showing here in terms of the rate of contacts per time. So we have that information, and it's just a matter of sort of putting that into the sort of the prior structure of these estimation. We do use approximate Bayes computation for this. So I think individuals in this group are sort of familiar with this type of approach. It's mainly sort of an approach to use when estimating a situation when the likelihood function is intractable or unknown. Here, of course, we don't have a likelihood across our stochastic differential equation model. What we can do, though, is select a set of parameters from what we think, you know, putting type priors on those and selecting those from the distributions that we give in terms of the prior, select those parameters, and then fit a model and see how well that then fits the observed data in terms of the different components. And then we can weight those different, yes?
Dave, I'm here.
Abigail's Adam.
I'm on my husband's.
Excellent.
I'm not Adam Taylor.
You're not Adam Taylor.
Wonderful.
But by this point, I'm sure he could speak on my behalf. So,
I've just made you co-host in case you want to share.
Okay. I can't, I don't have the slides up here. I'm just on
You know what? I will just tell me to push forward.
Okay.
When you need, just say next slide, and I will let you take it from here, unless anybody wants to go back to some of the slides that I slipped over in my ignorance. But I think this is actually a good part to start with then, Abigail.
Okay, so you got us through the epidemic, the stochastic model.
I stumbled my way through it, yes.
Okay, I think then this is a good point to start. I'm trying to remember where we left off. So we understand now that we sample distributions, and we have a stochastic model that includes that we have uncertainty that is generated by each stochastic iteration of the model. So each time we sample, we can get a different number of individuals transitioning between compartments. We also bring in uncertainty through our estimates of parameters. So I'll get to how we do that, but we use approximate Bayesian computation for parameter estimation, and this is a framework that allows us to bring in uncertainty through priors that we specify on each parameter. And the benefits of this is that the benefits of this for our overall approach is that it allows us to specify that prior information from external sources when we have that. Another advantage of this is it allows us to prioritize data that's more reliable in fitting the model. So for example, if we believe that observation, that the data that we have on deaths is more reliable than data on infections, then we can weight that a little bit higher. But the main value of the approximate Bayesian computation in our framework is being able to specify prior information. Can you go to the next slide? So when we use ABC, we estimate multiple parameters simultaneously. And so Dave, you probably already talked about the number of parameters that we're estimating.
I glanced over it.
Okay. I might actually want to go back a few slides to kind of go over that so that at least, yeah, I think if we go back, just go back to the a couple previous slides. Yeah, the next slide. So these are all of the, in red are all the parameters that we're estimating, and the key ones that we're actually interested in all of these, but the most important for transmission is for individuals moving from susceptible to exposed, and really to each of the infected classes being the observed infections I or the unobserved infections A. This is caused by the transmission rate, and this is defined as the average number of individuals that will be infected, that an infected individual will infect per day. And this is proportional. This is directly proportional to R0. And so beta is actually one of the parameters that we estimate. R0 is what we have data coming in externally. So that's why we derive an expression for R0 as a function of beta. But in the model, we're estimating beta, the transmission rate. And then the other important parameters here that we're estimating are the fraction of cases that are detected, R, and that's fraction of cases that are detected over all cases. So if that's 30%, that means that we're only actually detecting 30% of the illnesses that are truly out there and causing new infections. Then we have the probabilities of severe illness, the conditional probabilities of severe illness, which are these branching probabilities, alpha, kappa, and delta. and that's the alpha is the probability of hospitalization given infection, kappa is the probability of ICU admission given hospitalization, and delta is the probability of death given ICU admission. And if you go to, can you go to the next slide? So this shows us that for each of the arrows in the flow diagram has a transition time associated with it, which the inverse of that is the transition rate from one compartment to the next. Some of these arrows, some of these flows in this compartmental model also have these branching probabilities, which are defined by these probabilities, by these parameters that we're estimating. And our compartmental model wouldn't require those parameters. We induce those parameters on the model so that we can estimate them, because that's actually what we're interested in. From our big picture, what's driving this is that we want to know what are the probabilities of the hospitalization, the conditional probabilities of severe illness and death from our model, and we want to know the probability of the fraction, the probability of a case being detected or not. Okay, I think we can. Do you want to go to the next slide?
Well, I covered the next couple ones, so I think we should probably move on to the estimation part.
Yeah.
Just
okay.
Given the time.
I'll
move back to that here.
Yeah. So those parameters that we were just showing in red were the parameters that we're estimating, and each time we do a model fitting, we create joint posterior estimates of those estimated parameters. So that gives us, we might be able to estimate 5,000 sets of joint parameter estimates. Then to help us model, that gives us a range of uncertainty for each parameter, and it's a joint distribution because it's the way that all of those parameters fit in the model together. It's that instance. And so when we do forward simulations of the model, we iterate over all of those for example, those 5,000 joint posterior estimates, and that gives us a range of uncertainty. And so that is another way in which we estimate uncertainty, in addition to what is contributed by the stochastic differential equation model. All right, next slide. All right, so now we can get to some of the outputs. And so now we're showing data. We're showing data through the this chart is through the beginning of November, and so I think you can see we have good model fits in all compartments. I think it's interesting that sometimes you see these dots and it looks like there's no kind of the dots represent that data coming from the county health department. I think Dave, you probably mentioned that we get this daily email digest, and it looks like it's just a bunch of dots, but we can see a trend in that, and that's the value of the model. And so this is the classic eyeball test. That's how we're measuring model fit. And just a note to say that this is how most people are estimating the goodness of fits of their model, especially in the cases when we, like in our case, we're estimating a number of parameters together. And the prior distributions for each of our parameters help to specify the range over which we let those parameters vary. But there's still a number of different combinations that we could have of those parameters together. And so one of the values, so this model fit diagram helps us assess how well we're doing, and we iterate with our parameters until we see something here that works. But we also, one of the values of our model is that we're estimating a number of quantities together, and we're comparing that with common sense. and with this diagram and other pieces of common sense. So actually, if you want to advance, Dave, we get a number of outputs that help us determine what is a reasonable value. So R0, we're estimating this, and we have the mobility data that's coming in that's helping to define how much that reduces in time. And this trend that we're estimating in R0 follows very closely with our input from the mobility data. Dave, can you advance to the next slide? And this is our fraction of observed infections, R. And as you can see, there's a lot of uncertainty in this because we really don't know exactly how many infections are being observed. But we want to let this parameter vary over a much wider interval, since we don't really have good prior information on this. So we let this vary, and the uncertainty range is high, but it looks like as time goes on, we're able to observe a higher fraction of infections, but still with this very large range of uncertainty. Okay, and then these are our probabilities of severe disease, of hospitalization given infection, ICU admission given hospitalization, and death given ICU admission. So the green at the bottom is the hospitalization, the pink is the ICU admission, and the blue is the death. And so this is actually one of our key takeaways here, is that the hospitalization rate really decreased over time, and that was we think that's most largely due to the change in the age distribution in infections. So we kind of look at this as two phases of the epidemic, of these two different before and after these rates decreased. And in the first phase, which one example day out of that phase, April 20th, we had 23% of all infections coming from the 65 and older, the population of individuals 65 and older, and only 1% from individuals younger than 18. But by July 20th, that had decreased to 12% of individuals over 65, and had increased for younger individuals to 10%. And so and this trend has stayed relatively stable. I think the population, the current infection rate is around 11 or 10 or 12% of individuals 65 and older, and 12% or something individuals younger than 18. And so this really changes who's getting infected, their probability of hospitalization given infection. Now, once you get infected, the probability of treatment and health, the probability of doing well and not needing to advance to the ICU, that has decreased, and that could be due to treatment improvements. But the probability of death given ICU admission hasn't changed that much over time. So once you've kind of made it through all those filters, you it's the same likelihood of death as in the first phase of the epidemic. So those are some of the takeaways from our time varying probabilities of severe disease. Okay, can you move on? Okay, so this is our time varying case fatality rate and infection fatality rate. And these are really interesting. And going back to when I was showing the model, the model fits across all compartments slide, and saying that, you know, we have all of these pieces of information that we're fitting together. So we know that these should have been decreasing over time, right? Because of the infected population changing, and because of treatments improving, and so on. So when we're fitting the model together, we know that the change in the fraction of observed infections that has to change as that changes over time, and it might increase a bit as we are able to detect more cases. It can increase too much, because we still need, that actually forms the denominator of the infection fatality rate, which is deaths over all estimated infections. And so this is what I'm saying, in that we are fitting all of these together. So we know that that CFR, the IFR has to go down over time. So we can't have that denominator go down too quickly, or else the IFR will increase. So that's just from the modeling perspective. From the results here, there's some interesting takeaways too. The case fatality rate and the infection fatality rate. The infection fatality rate is lower, less than half of that of the case fatality rate when we take into account all of the infections that we estimate are out there. And we'll come back more to talk about this later in the context of influenza, if we have time. Okay. So I'm not going to get into the details here. We estimate the current number in compartment, so the current number of infected individuals out there observed, and then total estimated infections, meaning everyone who's out there contributing to new infections. And so just from our estimates of where we're at today, we have around 0.85% of the Los Angeles population is observed infected, and 0.2% of the Los Angeles population is actually infected out there, contributing to new infections. Okay. And let's just skip over this slide. All right, do you want to talk about this?
Yeah, absolutely. So, one of the things that we would like to do is to go a little bit more into depth of the different risk groups that are being affected by this, but the limitations of sort of a single homogeneous population compartmental model is that we can't do that. And we're also limited by the data that we have. We have aggregate counts in terms of the number, of infected per day and so on. We don't have information about the age categories or or age by ethnicity, by risk factors. And so what we decided to do was sort of project a model of risk onto the results of the epidemic model. And to do this, we were also limited by the data that's available estimating the sort of impact of different risk factors on the probability of being in the hospitalization if you're infected, the probability of ICU if you're infected, and so on. And most of that data to date is available in terms of marginal effects on single risk factors. And what we would like to do is combine those into a joint model. And so to do that, what we did is we used a technique that we've talked about before here, JAM, which is the Joint Analysis of Marginal Summary Statistics. And I'm not going to go into detail here about that approach, because I've talked about that before in the Biostat seminar. But what it does, it uses marginal estimates of relative risk, and we're able to get that from previous studies, mainly out of China, where they presented data here that's shown in this table in terms of those that have disease severity, and they actually have data that's sort of not presented in their paper but available that we could get and look at sort of marginal by age, by smoking, by sex, in terms of the number that were infected and how many were hospitalized and how many in ICU and how many died. And so we could use that data to construct marginal relative risks from their data as a reference data set to get the correlation structure, because we need that in the method that we use for JAM. We use the national NHANES data, and we pulled that data out we pulled that data out and then used it to estimate the correlation structure. And then the prevalence of the different risk factors that we used the Los Angeles County Health data to incorporate that information in there. The risk factors that we ended up incorporating were smoking, current smoking versus none. We came up with a categorical variable of sort of any comorbidity, and that was defined by the NHANES data of diabetes, hypertension, chronic obstructive, COPD, hepatitis, coronary heart disease, stroke, cancer, and kidney disease. And so that was data that we could get from NHANES and also estimates from the marginal effects that we could look at. We categorized age into 3 groups for this analysis, although we analyze it as 4 groups when we project on the model, but the 3 groups for this analysis are 20 to 44, 45 to 64, and 65 plus. We note that, you know, there is evidence that, so probably 75 plus and nursing home is a separate category, but again, we're limited in terms of the data, the risk model here. And then we included BMI categorized as 3 groups that you see there. When we run our analysis, this presents sort of the 3 different models that we have for hospitalization, ICU, and death as the sort of outcome in our logistic model framework. These are the marginal relative risks that we get from the previous data, the data that's available from China. And then these are the conditional relative risks that we calculate using our reference data and approach here. And in summary, you can see that sort of like any comorbidity is slightly attenuated. Smoking does go up in terms of its impact for hospitalization. BMI goes down, age also goes down. And that's because of the correlation structure of the combination of these risk factors in the NHANES data and showing that joint sort of estimates. So now that we have these joint conditional models, we want to use it to sort of construct a risk model for the probability of hospitalization given illness, ICU given hospitalization, and death given ICU. And we have these relative risk factors, but what we really need is sort of the intercept. What's the baseline probability or the average probability? And that's what we can pull from the epidemic model. And so we can pull out these corresponding parameters, and we can then construct a risk prediction model, so to speak, that if we sort of transform these effects that we get from the epidemic model, combine them with the conditional estimates that come from our joint analysis, that's the size here, and then a design matrix that includes sort of indicators for whether you're in a certain risk profile, centered by the frequencies of these risk profiles from our LA County data. We can now construct sort of these probability of hospitalization given infection by these different risk categories.
And
so,
centered by the frequency, not just their prevalence in the population, but their prevalence in infections.
Sorry, yes, that's a good point. So we start off with the prevalence in the population, but because we can peg this to sort of age data over time and other things, we can get that sort of the prevalence of that risk strata at that point in time for that risk profile. And so that can inform sort of our estimation as well. And so what do we get, just to give people an idea? There are 39 total different categories. This lists some of the more interesting ones. And you can see, for simplicity, we've sort of categorized them into 5 different risk categories based on sort of the overall risk of death there. But this gives sort of the age category, the BMI, smoking, and comorbidity. This is the population prevalence in Los Angeles County. And then this is the infectious prevalence of those infected, the prevalence there in the data that we estimate for the different time periods. And so you can clearly see that in the early time period in April, many more individuals were infected in the older age group, 65 plus here, than in the later time period, almost half of that reduced relative to then the prevalence in LA. And then you can see the corresponding estimates of the probability of hospitalization given infection, ICU given hospitalization, and then death given ICU. And then that goes down accordingly. And then of course we have sort of the younger age group where the estimate of risk is very low. And that's a large proportion of the population in terms of 14%. So again, what we can do is now project these different risk categories or risk strata onto our results. And so what we've done here is in each figure, it's split into the 2 time periods that we're looking at here, April 20th and July 20th. And then we have the different risk, the broad risk categories for this. And then we're looking at prevalence versus infected versus hospitalized, ICU, and death over time. And we can see how that changes in terms of the different risk profiles, where it's much more likely for the upper risk categories of risk 1 and 2 to be included in the ICU and the death count. And it's certainly dramatic to see the age difference between these two time periods when we look at sort of who's infected and compare these two in terms of the older individuals who are much more likely to be infected in the early time period, again, compared to the later time period. If we go on quickly, because I think this is one of the key takeaways, is then, it's been reported often that the CFR and IFR is sort of a marginal across the population, but it really is interesting and important to look at sort of the range of what we estimate in terms of the case fatality rate and the infectious fatality rate across these different risk profiles. In terms of the infectious fatality rate, it can go up to 8% for some of the highest risk categories. Actually, the highest risk category almost goes up to 15%. And then much lower again for the lower risk categories, and we can see that trend. Now, weighted average across the prevalences that we estimate across time, we do get summary estimates of these, and this is where you can see that overall the CFR and the IFR decrease over time. We can see that in terms of May 15th, here's August 1st and October 15th that we've estimated, and there is a decrease in that. And then, but the risk strata specific CFRs stay relative constant in that context. And what's really shifting is our proportion or the prevalence of these different risk categories at that given time frame. And it is also interesting then to compare these different estimates of these percentages to sort of what is reported in terms of the flu, which is about the CFR being 0.1% and the IFR being 0.05%. We have a few minutes left here, so I'm going to go quickly to the policy analysis and let Abigail take over.
Yes, so here we are trying to bring in a lot of the pieces. We estimate these different parameters as they were observed in LA County for the R0 as a function of T, or the reproductive rate as a function of time, and for the probabilities of severe illness. And we can create scenarios that modify both of those. So both the transmission rate and the probabilities of severe illness by protecting individuals at risk. So first, we're showing here the different policies that we implemented regarding the transmission rate. So in the gray, you see the R0 as observed through end of July. And in the blue, you see a moderate scenario in which we don't have a strict initial lockdown, but we do reduce transmission to what the transmission rate converged to, the population transmission rate ended up converging to. We in our moderate transmission scenario, we assume that the R0, that the transmission rate R as a function of time drops to that observed rate, and it doesn't drop below. And then we have the Trump scenario, where there's no transmission reduction, and this is just R0 is equal to the initial estimate, the RT, the reproductive rate as a function of time, is just equal to the R0 value observed at the beginning of the epidemic before any interventions. All right, next slide. And then we have our policies relating to protecting the at-risk individuals. So in these scenarios, we wanted to do something that was we wanted to model something that was a little bit more reasonable. So instead of protecting or shielding, i.e. isolating from transmission and assuming that these individuals are completely 100% quarantined in home, we look at a couple scenarios. First of all, we look at protecting individuals of advanced age, 65 and above, but not at looking at protecting all of the individual, for example, the risk profiles that are of very high risk, for the reason that a lot of those would be infeasible, actually, and kind of even protecting all individuals at 65 and above is infeasible, protecting meaning they are isolated at home consistently. So we also looked at some scenarios where we only protected, where we only assume that 50% of those individuals are protected, i.e. quarantined. And when we say 100% of these individuals or 50% of these individuals, it's 100% or 50% above the observed rate of individuals that were being infected. So we take in that LA County data on the fraction of individuals that are infected in each compartment, and we isolate above that percentage. So we're taking into consideration what actually happened and adding to that. Okay, and then the results. So so there are a number of scenarios that we look at that are the combination of the different transmission reduction policies, which here in shorthand we're calling non-pharmaceutical intervention related. Those are the transmission reduction scenario policies, and then the protecting individuals of advanced age policies are the protect policies. And so the column 6 is what we actually observed in LA County. And it's kind of hard to take in a lot of this information at once, but the big picture takeaways are that, yeah, the strict lockdown was effective and was really necessary. And it was necessary because it both reduced overall transmission and protected individuals at greater risk. So if we look at some of the policies that just protected individuals of advanced age, but didn't bring down the overall transmission rate, and for example, if we had the moderate NPI policy, the moderate transmission rate policy, we would have exceeded healthcare capacity, and we would have doubled the number of deaths. And this is because there are the people that are infected are not, it's not just individuals. There are a lot of moderate risk groups that would end up getting infected and contributing to these these populations of individuals that are severely ill and death and that die. So that's a really important takeaway from this scenario analysis. And so yeah, so what we're saying, and what our big takeaway is that the moderate NPIs and the protection of individuals of greater risk, that would have overwhelmed healthcare capacity and doubled the death count. So yeah, so those are some of our analyses. There are other scenario analyses we could run. We will probably do that, but our next steps in this modeling work are to develop a multi-population model. So far we have a unique approach to building a population level epidemic model, and then using that to intelligently inform rates for risk strata, for representing all of these different subpopulations that represent these different combinations of risk factors. Now, going forward, we actually want to create an epidemic model that is stratified to these different subpopulations. And the key subpopulations that we want to look at for the epidemic model are different race ethnicity groups and different ages. So we would want to look at the different combinations of race, ethnicity, and age groups. And we also want to look at more finely resolved spatial areas. So we might start by looking at the Los Angeles, the 8 service planning areas, the 8 spas. And because this is the big issue that everyone is trying to understand now, we will include a vaccination component so we can look at policies and we can modify different policies relating to vaccination. We will also look to refining the risk model now that there is more data that has come in and continues to come in. So if we have access to individual level data, which that is becoming an option now, we will be able to do that, and it will be interesting to compare the results that we've gotten using the JAM approach on the population level estimates from the marginal risks for these different factors. It'll be interesting to compare that to individual level estimates if we're able to get that data. So we will be updating our website shortly with new data. So it's been kind of offline for a little while, but we will be updating it very shortly. And we should acknowledge it's been a big team effort here within the department. So Lai Zhang, who's a PhD candidate working with Dave, has helped a lot with the JAM modeling. Emil, who has recently left us, was helping with some of the data science aspects of what we're doing. Wendy Kozin and Kayla De La Haye have been working as part of this project. Then Niraj Sood in the School of Public Policy has been contributing on the scenario analyses and the policies that we're running. And then we have some great support and team members from the Department of Public Health. So Paul Simon, who's the Chief Science Officer, and Will Nicholas also there. But then mainly Faith Washburn, who has been updating this daily data digest and really doing a tremendous amount of work there on that. So we're very appreciative, and it's been a great team, and we look forward to continuing this work together. So.
Well, thank you all for sticking around. We had some technical difficulties at the beginning, but I think we made our way through it. I guess for those who want to stay on for maybe a couple more minutes, if there are any questions, we can address that. But if there are no questions, that's okay too.
I have a question here. Very interesting work. While listening to what you presented, I was thinking, what if I were to do it? What do I do? So I have no clue of what this the stochastic model is, because beyond my knowledge. So I thought if I were to do it, I would use hidden Markov model. So on your diagram, your squares would be states. And some of the states are observed, some are latent. But anyway, you could have transition probabilities and let transition probability proportional to time.
Yes.
I wonder, I have no clue whether that approach would be good or not. I like your approach, although it's beyond my knowledge. Would you offer some insight in terms of comparisons between these two different approaches?
So that's an excellent question, and actually, I had it noted in one of the slides that the stochastic model that we've developed is actually an approximation of a continuous time Markov chain. So the Markov chain model would be built based on small interval probabilities, and the counting processes would be based on those small interval, the transmissions over small intervals, as we typically do to start a continuous time Markov chain model. And then in terms of implementing that in simulation, especially if we want to get these uncertainty intervals, there is an exact simulation approach that can implement that continuous time Markov chain, and that would be the use of Gillespie's algorithm, if you've heard of that or used that. Now, what we do is we take a more convenient approach, which I say convenient because from a simulation perspective, it's very straightforward. And what we're actually doing is approximating those counting processes using binomial and multinomial distributions with exponential transition probabilities. So we're not, the whole thing isn't Poissonian, but the whole thing is Markovian in that it comes from the basic Markov property. Now, you could actually look up and using Markov models and hidden Markov models are a way that these stochastic epidemic models can be developed. But generally, in terms of implementation and simulation, especially as the number of states increases, and when we want these confidence intervals, these predictive intervals for simulating the model forward, it's more standard to use these kind of approximation techniques.
Thank you.
Great question. Anybody else? Okay. I think we'll end there. Thank you all for joining us. And Duncan, I think we'll have a seminar next week. I forget who's on the list, but we can do that next week. See everybody next week. Thank you all for coming.